All right, I think we should get started. We have a good panel today, and so I want to make sure we have time. So with that, I'll turn it over. Good morning, everybody, and I'll turn it over to Dr. Bierkens to introduce our speakers.
Hey, good morning, everyone, and welcome to Grand Rounds. I'm honored today to introduce an exciting talk with a panel of health experts that have focused their career on providing care to World Trade Center providers and responders. First, we have Dr. Michael Crane, the Mount Sinai's World Trade Center Health Program's Clinical Center of Excellence Director for Mount Sinai. Dr. Crane leads the team of healthcare providers in the provision of monitoring and treatment services for over 21,000 World Trade Center responders. Next, we have Dr. Yelena Globina, a board-certified occupational and preventative medicine physician who serves as the medical director for the Staten Island Mount Sinai Selikoff Centers for Occupational Health Clinics. Next, we have Dr. Eileen Scigliano, a hematologist who provides oncologic expertise and education in case management services for World Trade Center patients with cancer and to World Trade Center healthcare program providers and administrative staff. We are also joined by Dr. Sandra Lowe's, the medical director of the World Trade Center Mental Health Program at Mount Sinai, who oversees all mental health administrative and clinical operations and leads a large team of professionals who provide the psychiatric assessment and treatment of 9/11 responders. Finally, we have Dr. Laura Crowley, the deputy medical director for the World Trade Center Clinical Center, and has been working on developing the best practices to evaluate 9/11 rescue and recovery workers and performing surveillance on their health status. We are incredibly honored to have you guys all today. Thank you again for joining us.
Well, thanks so much, Dr. Bierkens. I really appreciate a very generous introduction. Also, Dave, thanks for inviting us back. The last time Dave invited me, I was a no-show, having been stuck on the Triborough Bridge for 2 hours that wonderful morning. So hopefully there will be no Zoom Triborough Bridge equivalent this morning. So let's go ahead with the slides. We have nothing to disclose. So we're going to have a group presentation today. I'm going to talk a little bit about the exposure and the health impact of 9/11 and some initial efforts to treat responders. Dr. Globina is going to talk about monitoring and treatment. Dr. Scigliano about cancer care, and she will look through her microscope at least once for us. Dr. Lowe is going to talk about mental health, and Laura Crowley is going to talk about case management. Next slide. So these terrible images that follow are of the attack, the explosions in the tower, the collapse, people covered with dust as they were walking down the street, the wreckage of the buildings thereafter, and you'll see terrible, terrible destruction. Human beings are in that material there that you see behind you, behind the truck. Next slide. Most of the interest on the health impact of the responders initially, in addition to mental health, was on what they inhaled because they had lots of respiratory symptoms. And what we know about the exposure was very little because no one took any current samples. What we know about the dust is what people went out with plastic cups and picked up off the ground. The main components, cement dust and glass fibers. There was plenty of asbestos. Lead was found, PCBs, and then many, many other toxic substances, benzene, PAHs, dioxins. And then all during the event of the cleanup, there were diesel fumes from multiple generations of engines. And the pile, the material that was left over after the destruction of the towers, was on fire for at least 2 months, with workers going in and around and digging around in it. Next. So a very challenging environment. Respiratory protection was very, very incomplete at that point, and many other problems. It was wide open for many, many days. In addition to not knowing what the toxins were, there was very poor site control with large numbers of people very generously rushing forward to try to save others. There was no central registry. There was no any idea of intensity of exposure or duration of exposure. And so very much a lack of data about the early days of the exposure, really doing great wreaking havoc with any attempts to do epidemiology. Next slide. So, but people were getting sick. They were coughing. They were having terrible heartburn, nasal irritation, and the mental health toll was already being seen in the very early days. The government initially responded by a very limited treatment program and screening protocol, the Medical Monitoring and Treatment Program for 2002. Dr. Jackie Moline at Sinai and Steve Levin and others at Sinai started examining patients and found a number of upper and lower respiratory symptoms, like GERD, mental health, particularly PTSD and depression. There was philanthropic treatment. The Robin Hood Foundation very generously offered mental health services. People could use their private insurance. There were certain employers who offered medical care, particularly the fire department in New York City, who made a tremendous contribution. And I was involved with the program at Con Edison, where I was the medical director at the time. New York State Workers' Compensation, which is the avenue for people who are injured on the job in New York, was unfortunately completely not suited to this and just not up to the task. It being a one after one hearings and involvement of attorneys, and cases are slow and don't move forward, completely unsuitable for a mass injury scenario. Next slide, please. So we figure there is about 90,000 responders in all from those organizations that you see, particularly FDNY, police, Port Authority, construction, other city agencies, transit, sanitation, lots of volunteers. So about 90,000 people would be eligible for our program. There are also 400,000 people who lived, worked, or went to school in the area, and those have been named the quote unquote survivors who have a separate and distinct follow-up program. Next slide. And the folks at Mount Sinai have very similar job descriptions to those descriptions for the agencies, police, construction, utility workers, etc. Let's go to the next slide. So why was the Zadroga Act and the World Trade Center program necessary? Well, again, it was the failure of the workers' compensation system. It is not set up either for studying occupational disease, for making awards to occupational disease. It's far better about individual accidents where the evidence is clear, but occupational diseases get hung up, and when there's lots of exposure and lots of illness, it gets completely overwhelmed. Next slide. So Zadroga, how did it come about? Well, people advocated for the responders and understood the challenges about workers' compensation. And there was a good bit of published research, particularly from the FDNY, about the health impacts, particularly abnormal spirometry in FDNY personnel that was very striking, and lots of community and media interest. The next slide, please. In particular, the fire department, Dr. Dave Prezant, published papers which demonstrated the change from pre-existing, pre-9/11 health status for these responders. And this is just a graphic of the loss of FEV1, pulmonary function, of these previously healthy firefighters' status post-exposure to the 9/11. Next. And the other thing that's very important is that the Zadroga Act had a champion, Jon Stewart, that handsome devil, lambasted Congress show after show after show for not moving to help the responders, and he really moved it forward. So always thanks to John. Next slide. So the program was created by the Zadroga Act. I just lost my slide here. There we are. It's administered by NIOSH, National Institute of Occupational Health and Safety. It designates World Trade Center related medical conditions. So you don't have to go win a case to get program coverage for an illness that you are suffering from a workplace exposure. It creates separate programs for the responders, rescue and recovery workers, and the survivors, the members of the community. It created an epidemiologic study called the World Trade Center Registry, which is going on today, and also brought in community stakeholders to be involved in steering committees. Next slide. So a certified health condition, World Trade Center condition, is what gets treated. And that is very simply a provider attests that a patient's 9/11 exposures are substantially likely to have been a significant factor in contributing to the health condition. Provider signs that, sends it to NIOSH. NIOSH officer reviews it, and within about 2 weeks, the program can start covering that condition. So it's expedited care. And also mental health care is far more common to folks under World Trade than under workers' compensation. That is critical because of the burden of mental health illness that has appeared in the population. Next slide, please. The structure of the program, we have clinical centers of excellence at Sinai, NYU, et cetera. There is a program for the fire department. There's the survivor program for the folks living in the community. We all produce data. We have data centers, and we send it on to NIOSH for analysis and storage. Next. And so the program enrollment today, we have almost 80,000 responders enrolled, which is really pretty good out of presumed 90,000. However, the survivors program has been undersubscribed since the beginning, with only about 30,000 people enrolled. Next slide. Certified conditions, they're similar to the ones that Dr. Moline and Levin described early on: rhinosinusitis, GERD. The program adds cancers because of all the carcinogens. That's a very high number, 16,000, but 6,000 or more of those at this point, I believe, are non-melanoma skin cancers. So it's still awful, but not as awful as it looks right there. And a variety of other conditions, especially mental health conditions. Next slide. And this is your work. We have been sending patients to you since the beginning. ENT, gastroenterology, pulmonary. You have really, really helped us thousands and thousands and thousands of times. The next slide, please. And it goes on to the other departments. This has been an enormous team effort by Mount Sinai. Next slide. And this has been recognized by NIOSH because we just got a brand new 8-year contract to continue the program for responders at Mount Sinai, basically thanks to you and all that support. So we want to thank you for that, and especially for all the care you provide our patients during the pandemic. You've been doing a terrific job. So thanks so very much.
Good morning, my name is Yelena, and I will be presenting an overview of the annual medical monitoring and treatment program. Thank you for this opportunity. So as Dr. Crane described, and to set the scene for why we have the World Trade Center Health Program, it helps to remember that over 91,000 ground zero workers who are our patients inhaled, ingested, and possibly absorbed through their skin a wide variety of toxins. And to meet their needs of these exposed 9/11 responders, a federally funded World Trade Center Health Program, as Dr. Crane had described, was established, and it consists of no-cost medical surveillance, treatment, and research components. The medical surveillance part of the World Trade Center Health Program is formally known as the World Trade Center Annual Medical Monitoring Program, and it begins with a number of questionnaires. They're both self-administered and nurse-administered via an interview. The self-administered mental health questionnaire is reviewed by a social worker, and the physical health questionnaires are reviewed by a physician or a provider that will be seeing the patient. And at their initial visit, patients also complete an interview-administered exposure assessment questionnaire. So the IMQ, or the interview-administered medical questionnaire, is one of the ways data are gathered from the patients and used for the World Trade Center-related research. It is a 38-page questionnaire that includes information about work, details about their physical health, family and social history, as well as cancer screening. And this is an example of a pulmonary symptoms assessment. As you can see, it goes into quite a bit of detail. And details of the responder's exposure are very important in establishing a causal association between exposure and disease. And multiple studies of the responder population demonstrated that the intensity of exposure correlates with health outcomes. Therefore, we take quite a detailed 9/11 history and also pre-9/11 exposure history in the form of this exposure assessment questionnaire, also known as EAQ. And this is a list of toxins used to assess pre-9/11 exposure. As you can imagine, and Dr. Crane had mentioned, workers from various occupations participated in many different types of cleanup, search, and rescue operations. And this is how their job descriptions are coded in the EAQ. And this is a page from the exposure questionnaire that ascertains intensity of the responders' exposure on 9/11/2001. Then we go on to assess exposure during the month of September and exposure assessment for the months of October 2001 through June 2002 when cleanup operations officially ended. We asked about location of their work at ground zero, level of dustiness and smoke are also ascertained. And after the questionnaires are completed and reviewed, we do some testing that includes basic labs, imaging, spirometry, and EKG when indicated. And then testing is followed by a general physical examination and reporting the results to the patient along with recommendations in an after visit summary. The mental health assessment is always a part of the evaluation. You will hear much more about it from Dr. Lowe. So certain preventive care is also included in the annual monitoring program, and it consists of flu, shingles, and pneumococcal vaccinations whenever appropriate, as well as cancer screening, which is based on the U.S. Preventive Services Task Force guidelines. So responders who are determined to have a World Trade Center exposure-related illness or need workup for symptoms that may be suggestive of World Trade Center-related conditions are referred to the World Trade Center treatment program. And that takes form of an outpatient doctor's visit with which we're all familiar. One thing that sets it apart is establishing a causal relationship and advocating to the federal government on behalf of the patient in the form of certification. And this usually happens during the first few visits to the World Trade Center treatment program. Now, once the patient is certified as having a World Trade Center related medical condition, they have full access to the benefits offered by the World Trade Center Health Program. Excuse me. And this includes medications, testing, follow-up within the World Trade Center Provider Network. So the World Trade Center Provider Network includes physicians in various specialties and many other healthcare professionals. We also offer a smoking cessation program and extensive nursing education programs. And this is a list of commonly utilized specialists, the commonly certified conditions, which reflects the list from a previous slide of most commonly utilized specialists to treat the World Trade Center related conditions. They generally fall into broad categories of airways and digestive disorders, cancers, musculoskeletal disorders, and acute traumatic injuries that may have been sustained at ground zero. So, and our patients remind us daily of why we do what we do in providing the most generous feedback about our care. And in conclusion of my part of this presentation, and in the words of this patient, I would like to express my gratitude to you for your altruism during the pandemic and beyond. Thank you all for all that you do for people just like me. You too will be rewarded. Thank you.
Good morning. I'm assuming everybody can hear and see my slides.
We can hear you, but no slides, Eileen.
Oh, you know what? I don't think I shared. I've only been doing this. Sorry.
We see your email.
You see my slides now?
You're good, Eileen.
Yeah, great. Okay, thank you. Good morning. So I'm going to be giving an overview of the cancer-related benefits to which our World Trade Center Health Program members are entitled, and then speak a little bit about the cancer that we're seeing and actually some precancerous conditions we're seeing in the World Trade Center exposed populations. So in 2012, cancer was added to the list of World Trade Center related health conditions on the recommendation of the Scientific Technical Advisory Committee, on the basis of at least 70 known and potential carcinogens that were identified in the environment in the smoke, dust, and volatile contaminants, in addition to the carcinogenic burden of over 90,000 liters of jet fuel that were combusted. And as mentioned before, the diesel exhaust from trucks and construction equipment that were present for many months. And I also wanted to mention the potential role of chronic inflammation that was a consequence of many of these inhaled toxins at that time. So the World Trade Center provides medical benefits related to cancer in the form of cancer screening, as mentioned, which follows the USPSTF guidelines, cancer diagnostics, which is a program where coverage is provided for any diagnostic evaluation in an individual who may be suspected of having a World Trade Center related cancer. So consultations, scans, those are all covered by the program. I'm going to speak a little bit more specifically about what's required for cancer certification. And then finally, cancer treatment. So the program provides coverage for all medically necessary cancer treatments for certified World Trade Center related cancers provided by affiliated providers. And it typically follows NCCN guidelines. So as mentioned, this is the United States Preventative Services Task Force Grade A and B recommendations for cancer screening that the World Trade Center Health Program follows. And so we do screening, we cover screening for breast, cervical, colorectal, and lung. And I do want to point out that prostate cancer screening is not covered by the program. So cancer certification enables members to receive cost-free treatment for the certified cancer and for certified medically associated conditions. So for example, if a patient develops toxicity related to chemotherapy, then any care related to that will be covered by the program. In order to receive a cancer certification, there are certain eligibility criteria. The individual responder has to be an enrolled member of the health program. They have to have a documented World Trade Center related cancer diagnosis. And I've only listed those few diagnoses that are excluded. And they have to meet minimum exposure and latency requirements. So this chart delineates the time intervals, the exposure time intervals, and the minimum hours at each level of exposure that are required when the responder is in this New York City disaster area location, which is south of Canal Street, and a few other locations. And so the minimum hours at these levels of exposure, and the exposures are defined here. The most intense exposure, as you can imagine, would be if the responder was caught in the dust cloud. In addition, these are the cancer latency periods that were recommended after a thorough review of the somewhat scarce cancer latency literature, and led to recommendations of what are somewhat generous minimum cancer latency requirements. As you can see, typically solid cancers do have a much longer latency period, but these are the minimum requirements for certification. So this is a chart that shows the numbers of members who are enrolled in the World Trade Center Health Program that have at least one certification for the category of illness here. And I just wanted to point out the numbers, and this is responders and survivors combined. So just over 30,000 members have been certified for at least one cancer diagnosis. And this likely underrepresents the actual numbers of responders who've developed cancer, because all responders who've developed cancer are not enrolled in the program, although most are. And even responders with cancer who are enrolled in the program may not have sought certification. These are a list of the most common cancers that we see. And as Dr. Crane mentioned, most of the cancers are non-melanomatous skin cancer. But as you can see, prostate cancer is the second most common cancer we are certifying in these individuals. So this chart summarizes some of the most recent studies looking at cancer incidence in World Trade Center exposed populations. And as you can see in all of the studies, prostate and thyroid cancer have been shown to have a significantly increased, and these are the standard incidence ratios that are significant, have been shown to have a significantly increased incidence in World Trade Center responders compared to the general population. Weber's study actually did a direct comparison of cancer incidence in the firefighter responder group, and the comparator arm they were able to use was non-exposed firefighters, and these are firefighters from the Career Firefighters Health Study cohort. So this was a direct comparison of exposed firefighters and non-exposed firefighters, and they again showed an increased incidence of thyroid and prostate cancer in this group. Of course, there are certain challenges to these types of incidence studies, the first being something known as the healthy worker effect, which might actually lead to a bias toward the null, because healthy workers and in general, responders are healthy workers, may be less likely to have additional cancer risks, such as obesity and smoking, which would be expected to be more prevalent in the general population. In addition, using the general population as a comparator arm might actually lead to a bias away from the null, because the general population may not have occupational risks that are certainly seen in responders that might lead to an increased risk of cancer. And in fact, firefighters and police officers who have not been exposed to 9/11 have an increased incidence compared to the general population of US males of prostate cancer. So exposure in these occupations does increase cancer risk. And finally, there's surveillance bias. We know that increased cancer screening might lead to the appearance of an increased incidence in a given population. And this is particularly true for prostate cancer, for which screening is readily available. And in fact, the study did show that the prevalence of prostate-specific antigen or prostate cancer screening was elevated in World Trade Center, the World Trade Center registry population, compared to the general population. And these were self-reported self-reports of prostate cancer screening. The general population they looked at was from the National Health Interview Survey. And as you can see at each age group, the darker bar represents the increased prevalence of prostate cancer screening in the World Trade Center group compared to the general population. This report by Hashim and colleagues, actually from Sinai, tried to ascertain whether the increased incidence in prostate cancer seen in responders could be linked more directly to World Trade Center related exposure rather than simply a consequence of enhanced surveillance. But what they did was compare the incidence of prostate cancer in World Trade Center responders to the general population. And this data came from the New York State Cancer Registry. And this chart on the upper right here shows the age-specific incidence ratios for prostate cancer, comparing these two cohorts. And the red bars indicate that there was a higher incidence, in fact, in responders, but it was only seen in the earliest or the youngest age groups and the older age groups, and not in the typical age groups where screening is typically more prevalent and where prostate cancer screening is recommended. And one would expect that, excuse me, one would expect that if incidence was related to increased screening, you might expect to see that increased incidence reflected in this population, and it was not. They also looked at to see if there was an association between level of exposure at 9/11 and clinical features of prostate cancer. And this is shown in the chart below. And so these are varying levels of exposure. And again, the definitions of exposure are listed here. And what they did identify was a higher exposure in fact, the highest level of exposure was associated with more advanced clinical stage of prostate cancer with an odds ratio of over 5. So at the highest level of exposure, there was a higher risk of having stage 3 or 4 prostate cancer rather than the typical localized disease, which is usually seen at diagnosis. And finally, they didn't find any correlation between exposure and the number of prostate cancer screening events. Again, these data taken together suggest that perhaps increased screening may not fully explain the higher incidence of prostate cancer seen in responders. I want to switch for a minute to another precancerous lesion that has been identified in World Trade Center responders. So we know that environmental exposures, such as those present at 9/11, certain occupations, chronic inflammatory conditions, may be associated with an increased risk of something known as monoclonal gammopathy of undetermined significance and the disease multiple myeloma. So monoclonal gammopathy, or MGUS, is the precursor disease for multiple myeloma, and it's associated with about a 1% per year risk of transformation to multiple myeloma. And these conditions have been associated with these environmental exposures and occupations. However, World Trade Center incidence studies so far have not consistently shown an increased incidence of multiple myeloma. There were a couple of case reports. One came out early on patients who developed multiple myeloma in the general responder cohort. This was published by Moline in 2009. And what they reported on was 8 patients in the responder cohort at that time who developed multiple myeloma. And obviously the number is pretty small, but there were only 6.7 expected cases. But more interestingly, of those 8 patients, 4 of the patients were under 45 years of age at diagnosis. And this is very unusual for multiple myeloma. It is rarely seen under the age of 40 and is uncommon under 50. Only about 10% of individuals under 50 are diagnosed with myeloma. In the second case series reported by Landgren in 2018, they looked at the cases of multiple myeloma in firefighters who were exposed to 9/11, and they identified 16 patients with a median age of 57. And in this group, what was interesting was that of 14 of these 16 patients for which they had information, 7 of them had what's known as light chain only multiple myeloma. This is a relatively uncommon subtype of myeloma, usually seen in only about 20% of myeloma patients. And again, although the numbers are small, 50% of the firefighters who developed myeloma had this less common and worse prognosis type of multiple myeloma. But given these sort of interesting findings, Landgren went on to do a serum prevalence study to see whether or not the precursor disease for myeloma might be more prevalent in responders. And so they actually collected serum at monitoring visits in firefighters who were exposed at 9/11 and compared the prevalence of monoclonal gammopathy to the general population of Olmsted County. It turns out in 2006, there was a study published in the New England Journal of Medicine that actually looked at the prevalence of monoclonal gammopathy in the entire population of Olmsted County. So this was the comparator arm for this study. And what they found was there was a nearly 2-fold higher prevalence of monoclonal gammopathy in the firefighter responders compared to this general population. These results have actually been expanded and reported in 2020 by Zeke Owens from the Montefiore Group, looking not just at firefighters, but also general responders from the Stony Brook CCE, and again identified a nearly 2-fold increase in the prevalence of monoclonal gammopathy in firefighters, general responders of 9/11, compared to the general population. I want to speak about one other precancer lesions that's been identified in World Trade Center responders, and that's clonal hematopoiesis. So clonal hematopoiesis is the acquisition of somatic mutations in blood cells leading to clonal expansion and has been associated with an increased risk of hematologic malignancies, specifically myeloid malignancies, as well as cardiovascular disease. In this study, JASRA, and colleagues compared the prevalence of clonal hematopoiesis using targeted sequencing in blood samples. They compared the prevalence of clonal hematopoiesis in World Trade Center exposed first responders, firefighters, and EMS workers compared to non-exposed firefighters. And they found a significant, with an odds ratio of over 3, increased prevalence of clonal hematopoiesis in the exposed firefighter cohort. These listed below are the most frequently mutated genes they identified, TET2 and DNMT3A, which are the genes most frequently associated with myeloid malignancies. So this study of this precancerous lesion taken together with the monoclonal gammopathy really have important implications for screening and possibly for preventative measures in this at-risk population. And finally, I just wanted to close with this study that looked at cancer survival in World Trade Center responders. So access to medical monitoring and treatment programs that provide screening, diagnostic procedures, and treatments for certified cancer at no cost to the patient may improve outcome. And in this study, both cancer-specific and all-cause mortality were compared in 3 groups: responders with cancer who are enrolled in the World Trade Center monitoring program, responders with cancer who are not enrolled in the World Trade Center monitoring program, and non-responders. And what they found was that in both all-cause mortality and cancer-specific mortality, these were both decreased in those responders who were enrolled in the monitoring program compared to non-responders. There was no significant difference between the non-monitored responders and the non-responders. And so these differences were significant with hazard ratios of 0.64 and 0.72. And on the right are depicted the Kaplan-Meier survival curves that show the monitored cohort in green and show improved survival, overall survival, as well as cancer-specific survival in the monitored cohort compared to non-responders, as well as to the non-monitored responder group. So these survival benefits may result from a variety of factors, but I did want to call attention specifically to case management, which is the model that the World Trade Center Health Program uses to monitor and follow its World Trade Center responders with cancer, and may in fact lead to improved survival through better adherence to screening and treatment. And Dr. Crowley is going to speak a bit more about the case management program. And I am going to stop sharing and introduce Dr. Sandra Lowe, who is going to speak about mental health in our responders.
Hi, everyone. Just trying to, are you able to hear me clearly? Okay.
Yes, we're good.
Great. Thank you, Dr. Sigliano. My name is Sandra Lowe. I am a psychiatrist and serve as medical director for the mental health program. And I'm going to speak about the mental health of the responders 21 years after 9/11. Brief overview. I'll discuss disaster exposure and mental health outcomes. And I'll speak about some of the factors that mediate illness trajectories, including why some individuals remain symptomatic today, and briefly describe how the mental health program is responding to the current cohort needs. Finally, I'll touch upon how our work has informed disaster response. In addition to the environmental toxin exposure already described, tens of thousands of individuals were also exposed to psychologically traumatic events on 9/11. That day, almost 3,000 people were killed, and for those who survived, there was immediate risk to life. Thousands were injured and feared their death as they evacuated the burning and collapsing towers and tried to outrun that huge dust cloud. They witnessed horrific events, people falling and jumping from towers, the violent death of many, including some of their co-workers. And some continue to have nightmares of friends that they left behind as they try to save their own lives. Over the many months that followed, residents were displaced from their homes or lived in disaster aftermath. And those new recovery operations worked long hours under really treacherous conditions, often assigned to disturbing tasks for which they were not at all prepared, such as handling burned bodies and human remains. Now, this double exposure to terrorism and environmental disaster increased the risk of developing a multitude of illnesses and has deeply influenced the nature, the complexity, and the persistence of subsequent health issues. Considerable research has documented the relationship between this exposure and elevated rates of psychiatric illness. These in the chart are the illnesses recognized by the program as exposure related. The most common are PTSD, anxiety disorders, and depressive disorders. And the number of patients diagnosed with psychiatric conditions, over 21,000, is widely regarded as an undercount. About 22% of all certified conditions are psychiatric, and current prevalence rates vary substantially across cohort subgroups, ranging from about 9 to 25%. Now, before moving on, I do want to highlight that while exposure to trauma is a known risk factor for developing psychiatric illness, most individuals who experience traumatic events cope well or recover. That is, traumatic exposure by itself does not result in illness most of the time. And although the biological underpinnings of trauma are beyond the scope of this presentation, I'll briefly mention that trauma exposure activates a stress response that's mediated by the HPA axis, which varies in severity and may be adaptive or not. However, when the response is chronically dysregulated, as it is in PTSD, the stress results in a compromised HPA feedback system. This leads to a cascade of changes in the nervous, cardiovascular, endocrine, and immune systems that continues to signal presence of danger even after the event has long passed. And this is the presumed pathway to trauma-related psychiatric and physical illness. This dysregulated alarm system signaling danger when all is actually safe in the present is poignantly described in this quote. Trauma is much more than a story about something that happened long ago. The emotions and physical sensations that were imprinted during the trauma are experienced not as memories, but as disruptive physical reactions in the present. And that's Dr. Bessel van der Kolk, a psychiatrist who has done incredible work in helping us understand trauma and trauma disorders. Now, I'm going to move on to the factors associated with the persistence of trauma-related illness. Why is it that we continue to see symptomatic illness 21 years after 9/11? Well, various longitudinal studies among responders have shown that illness trajectory is mediated by the severity and duration of the exposure, such as early arrival at the ground zero, getting caught in the dust cloud, sustaining injury at the site. Individual factors, genetics, trauma history, coping style. The availability of psychosocial resources, such as community and family support, or lack of resources, such as barriers to accessing mental health care. I'm going to focus on these three: comorbidity, occupation and training, and post-stressor adversities. Starting with medical and psychiatric comorbidity. Exposed responders bear a substantial health burden. Over 58% have at least one exposure-related health condition. And note that this does not include the non-World Trade Center conditions such as cardiovascular disease and diabetes. Excuse me. This figure is from the FDNY 20-year report on the World Trade Center effects and shows the comorbidity of physical, psychiatric, and cancer illness in exposed firefighters as of 2021. Note the significant overlap in these conditions. About 42% of exposed responders have diagnoses in more than one illness domain. 21% have both physical and psychiatric illness, and 7% have conditions in all three domains. A considerable number of studies have found that comorbidity is the factor most strongly associated with chronic illness trajectory. There are many reasons for this. I'm just going to mention the downstream psychosocial consequences of multi-comorbidity, which include forced early retirement, financial difficulties, loss of identity as a worker, really important for responders, loss of community, and ruptured relationships, and that's just naming a few. All of these contribute to chronic illness. Now looking at morbidity and mortality by occupation and training. A 2007 paper by Perrin and colleagues was one of the first to compare workers from different occupations responding to the same disaster. The authors found that PTSD prevalence differed substantially across occupations and was significantly higher among non-traditional responders, that is, construction, engineering, sanitation, cleanup workers who had no training in disaster response. Subsequent reports have similar findings. A recent paper found increased prevalence of suicidal ideation among non-traditional responders, 12%, compared to the US population, about 5%. And a longitudinal study examining the overall mortality of the 9/11 cohort found increased suicide death among responders only. And the majority of these deaths, 76%, occurred among the non-traditional responders. The last factor I'm going to touch upon is subsequent trauma exposure. We know already that populations with a history of trauma may be more vulnerable to adverse consequences if they have future traumatic exposure. Within the 9/11 cohort, exacerbation of psychiatric symptoms has been noted following natural and environmental disasters, outbreaks of wars. And during the first year of the COVID-19 pandemic in particular, many responders reported disturbing parallels to events surrounding 9/11 that triggered re-experiencing of their trauma, and they had worsened symptoms. In addition, there is an annual increase of psychological distress around September 11th, referred to as the anniversary reaction. And this is commonly reported by responders due to increase in triggers, media in particular, around that time of the year. Now, It's also important to recognize factors associated with resilient trajectories. A study looking at peri and post-trauma protective factors 12 years post 9/11 found that resilient trajectory was associated with higher perceived preparedness for the response work, social integration, positive coping skills, and importantly, family and work support while working at ground zero. And an interesting study looking at positive psychological change in individuals 15 years after 9/11 theorized that resilient trajectories are associated with the largely shared experience of 9/11, in which people were forced to rely on others, and that this reinforced effective coping skills. So how are we meeting all of these needs? Well, the mental health program at Sinai comprises a large and wonderful team of social workers, psychologists, and psychiatrists who provide health surveillance, evaluations, trauma-informed treatment, and case management. Utilization of mental health services has grown tremendously. The number of visits has increased by 88% over the past 5 years alone. This growth is driven by persistence of symptoms, previously undiagnosed conditions that are identified due to surveillance, which highlights the importance of monitoring that Dr. Glavina discussed. Onset of psychiatric symptoms triggered by new medical conditions, such as the cancer diagnoses discussed by Dr. Sigliano, and increased complexity of care requiring case management. Dr. Crowley will next speak about that. Lessons learned from 9/11 have informed disaster response protocols for almost 2 decades. We know that trauma symptoms may arise years later, can endure for decades, and that the effects of exposure vary across groups. We know that illness trajectory is mediated by some factors that are actually modifiable, and that disaster training for responders is critical to limiting morbidity. Therefore, there are meaningful actions we can take to diminish morbidity and suffering. We need to monitor populations post-trauma, identify at-risk individuals, and ensure access to treatment. And we need to provide tools to improve coping skills and training, especially for frontline workers. And because we have learned the value of connectedness, that community can be protected, we need to encourage building of support systems, not only in the community, but also in the workplace where we spend most of our time. I thank you, and I will now turn over the presentation to Dr. Crowley.
Good morning. My name is Laura Crowley, and I am a physician that works with the World Trade Center program and actually our case management team. Next slide. So starting here, I just want to start with a picture of some of the members of our dedicated World Trade Center Health Program case management team. And this team is led by Dr. Jermaine Nelson and Mr. Charles Joyner. Next slide. As Dr. Crane and our presenters have noted, times have definitely changed since the beginning of the program. And one area of significant change has been the addition of case management branch of services over the past 5 years. And really its growth over the years. We have seen some patients remaining stable in their World Trade Center related conditions, be it rhinitis, sinusitis, GERD, asthma, or COPD, and continuing to require routine follow-up and surveillance for their cancer screening. while others had had progression of their disease and increased care needs as it related to the World Trade Center conditions. And then there are those that are being diagnosed with newly diagnosed cancers, as noted by Dr. Sigliano. And that could be anything from a solid tumor like prostate, kidney, or lung to liquid tumors like multiple myeloma or lymphoma. Soon became really clear that there was a need for coordination of benefits and really providing support to our patients on what could be covered through the program, especially given the fact that we had patients that were across state lines, be it in Florida, North Carolina, or really anywhere in the United States that have retired and were actually coming back up to Mount Sinai to get their World Trade Center care or for their care related to a new cancer diagnosis. Next slide. So, sorry, Adam, could you just back up one slide? Thank you. So what is World Trade Center case management? So our team is really an inclusive team that includes physical health and mental health physicians and social workers, nurses, patient service coordinators, our claims, and our billing team. The team's dedicated to assisting patients with their coverage benefit and really ensuring that they have connectivity with their treating physicians and appropriate authorization of services to ensure their care moves forward. Next slide. There are approximately about almost 4,000 patients in the Mount Sinai World Trade Center cohort that have been diagnosed with one or more cancer. And almost a third of those are managed by our cancer case management team, with a quarter of those needing really high level of care and have been identified as high acuity patients and requiring frequent follow-up. In addition, we have 500 other patients who are in what's called a diagnostic category that are being worked up for a possible cancer diagnosis related to their exposure. Next slide. The structure of the cancer case management team, as I mentioned, consists of a large group of staff with varying expertise from the mental health professionals like Dr. Lowe's team, the physical health medical review team, including Dr. Sigliano, myself and others, nursing leadership, nurse case managers, care coordinators, and patient service coordinators. Next slide. As a result, we hold multidisciplinary rounds, and this is really a mechanism for us to organize and coordinate the health and care services to meet really the individual's need, especially with such complex care that's required. This may include anything from surgical procedures, chemotherapy as an outpatient, admission for an auto BMT, allo BMT, to our lung transplant patients. And the teams really bring together the expertise and skills of different professionals and specialists so that we can assess and plan and manage the patient's care jointly. And this construct is really critical to ensuring patients have continuity of care within the World Trade Center program and access to the many resources to our patients throughout the program. Next slide. We hold multidisciplinary rounds, clinically reviewing the cases so that we can address the patient's needs within the scope and guidelines of the program. And the World Trade Center program has very strict medical program guidance documents that must be followed and really make sure that we're in the boundaries of the program so that the patient can be covered for their services. Next slide. So how do we stratify the patients? We have 10 case managers, and early on, our Mount Sinai case management team created an acuity tool, recognizing the need to have a numerical score to score the patient based on their level of severity of disease and the intensity of case management needed. And this was based on multiple factors, and some of those were if they required chemotherapy, surgery, if it was a transplant patient, a hospice patient, palliative care, their comorbidities, both World Trade Center and non-World Trade Center. And then this would drive the level of care for the patient so that we could identify the frequency of follow-up with the patient and many times the family as well. An example, maybe a skin cancer patient, and a skin cancer patient may be one that had a removal of their skin cancer and then would be identified as a level 1 and would then be followed on a yearly basis for coordination of their benefits with the dermatologist. Another example may be an auto BMT patient who may be admitted to the hospital for a bone marrow transplant, and they would be identified as a level 4, requiring very close follow-up by our nurses on a weekly or daily basis. Next slide. I use this slide really as a mock patient and really utilizing it to highlight how case management intersects with our fragile patients, both cancer and lung patients alike. And this happens to be an interstitial lung disease patient. And, here at Mount Sinai, we're so very fortunate to have a phenomenal pulmonary department dedicated to the care of our World Trade Center interstitial lung disease patients and asthma and COPD alike. So in this patient, we have a 57-year-old male who has a typical, unfortunately, triad of World Trade Center related conditions, rhinitis, sinusitis, and GERD, who had presented with cough and shortness of breath. And after a complete workup, he was found to have a restrictive pattern on his PFTs, interstitial infiltrates on his X-ray, which then prompted a CAT scan showing basal subpleural reticular pattern with honeycombing, and ended up having a biopsy revealing a UIP pattern. He was treated initially with oral steroids, unfortunately had minimal improvement, and then went on to get immunosuppressive agents with limited to no improvement. He was then referred to a lung transplant center, and this would be a case, next slide, where case management would be critical into helping move this patient along and get them to the right place. So ILD, as many of us know, is a complex disease requiring very close follow-up and coordination of multiple subspecialties. So for this patient, we would be identifying centers of care, lung transplant centers, and then helping to authorize the services through the World Trade Center program. This patient would more than likely be addressed on our multidisciplinary rounds. And in terms of follow-up, would be followed up quite frequently, both pre-transplant, during their hospitalization, and post-transplant. Next slide. So in summary, just a few take-home points. As many of you may or may not know, Mount Sinai has actually been awarded another 8-year contract to care for our World Trade Center Health Program patients. And we're really so privileged to continue that care for our responders. 5 years today, case management in World Trade Center Health Program was really in its infancy phase and has since grown to this robust case management team dedicated to responding to the growing needs in our aging cohort. Continuity of care is of the utmost importance for our patients, and our case management nurses are really critical resources for our patients to connect them with treating physicians and to ensure patients receive services and their benefit under the program. Our case management team is proud of the fact that many of the patients in case management are known by name, and their relationship with their case management nurses is very close, where the patients may be calling them, that's their first call when really anything happens related to their care or otherwise. As Dr. Sigliano highlighted, early diagnosis of World Trade Center related cancers with screening programs like our lung cancer screening program, the colon and breast screening program, is really critical to our patients. We would like to end with a special thanks to all Mount Sinai providers that care for our World Trade Center Health Program patients, and certainly welcome any referrals for those that may be in need of our care. Moving forward, our staff continues to look forward to continuing to educate our providers about World Trade Center related conditions and the program benefit. And certainly, we look forward to providing excellence in care through our Mount Sinai healthcare system. Thank you.
That was terrific. It was wonderful. It was really a terrific presentation. Really appreciate it. There's not any questions in the chat at the moment. We're a few minutes over. I don't know if any will pop up while I'm just saying thank you to all of you for coming today. It was really they were actually do great work, right? Great work, and kudos, because it's really a privilege to have your group come and talk to us at Grand Round and see the amazing work that you have all done over the past 20 years. So I want to say thank you very much on behalf of the Department of Medicine. So have a good day, everybody. Have a nice one. Thanks, everyone. See you soon. Take it easy.